by some sort of serendipity or synchronicity, what's been on my mind the last year or two happens to fit perfectly into the theme of this conference of challenging mainstream paradigms. And my challenge is to the routine treatment of chronic diseases with drugs, which focuses on symptoms instead of causes, and it really reflects an unwitting, unspoken, implicit assumption that we can extend lifespan indefinitely by administering drugs. So I've called this Seeking Immortality, with a question mark, not a colon as in the program. And some of the statements I make may strike you as maybe a bit excessive, overblown. In fact, I'll be a bit disappointed if they don't. But everything I say is based on mainstream documentation. And on my website, there's a PDF you can download, What's Wrong with Medicine, that has dozens of books, a number of articles, some official reports, all of which state or document what I'm about to tell you. And in fact, I think this is more a debunking than a challenge. When we don't feel well, it's for broadly one of two reasons. Either we've been attacked from outside, in which case we talk about an infectious disease, or there's some sort of malfunction inside ourselves. There's a chronic disease like heart disease or cancer or arthritis, that sort of thing. Those are two very different ways of getting to feel ill, so you might think that we ought to treat them differently, but we don't. Current practice is, in both cases, to attempt to treat them with drugs which are supposedly specific and do only what we want them to do. When in the case of an infectious disease, we can identify a specific cause of illness. Not only that, but bacteria and parasites have physiologies that are sufficiently different from our physiology that we have found substances that can kill them differentially, kill them without killing us, at least sufficiently differently. And what's more, to get over an infectious disease, we usually have to take a drug for a limited period of time. By contrast, in the case of the malfunction inside of chronic disease, there is no specific identifiable cause, no single cause. It's a systemic disturbance, and the question is, if you want to cure that, it means restoring homeostasis, which refers to the fact that our bodies manage to function in a stable way, a reasonably stable way, even though they're immensely complicated systems. There are innumerable reactions going on all the time. Those reactions are switched on and off by signals that go back and forth. There's feedback all the time, and it's an intensely complex system where it doesn't seem rational to think that that you can fix something wrong with that system just by adding one substance. What's more, if it's a chronic disease, we are being administered drugs for lifelong use. And in that case, our systems are also being affected by the cumulative effects of the so-called side effects. Now, when I say that there's no specific identifiable cause of illness, current theory is that cancer, for example, requires several steps to occur, and no single one of those is decisive. No single one alone will cause the cancer. As far as heart disease, cardiovascular disease goes, the Institute of Medicine mentions that there are 243 risk factors for that. So there's obviously no way in which you can treat 243 different risks, certainly not with drugs. So having said that there's no single identifiable cause of chronic disease, I'm going to tell you that there is a single clear cause of chronic disease. It's getting older. If someone dies from heart disease, from cancer, what does the death certificate say? What do we say about it? We say this person died from natural causes. So the thought that we can prevent organ failure or cancer amounts to saying that we can prevent aging, and that's why I chose the title Seeking Immortality. That's implicitly what we're doing, without, of course, admitting it. And one way of disguising that fact is to describe getting older as though it were an illness. We use semantics. Normal changes with age are described as abnormal. We don't talk about our hearts and arteries getting older. We say we've got cardiovascular disease, as though it were the same sort of thing as when we get the flu. We talk about hypertension, blood pressure too high, pre-hypertension. You're not ill yet, but you're going to be. And I'm going to say a lot more about blood pressure later. We talk about pre-diabetes, talk about high cholesterol and bad cholesterol, when actually cholesterol is one of the substances our body makes because it needs the cholesterol. The cholesterol is part of all of the cell membranes. We talk about dysfunctions. Clearly, all of these things happen normally with age, but we describe them as though they were abnormalities. So what I've said so far is really based on first principles. On first principles, you wouldn't think that you could cure chronic diseases with drugs. But we've been doing it, we've been trying it for decades. So there ought to be some evidence as to whether it works or not. We've been taking blood pressure lowering medications and blood thinners and statins. And the question is, have they improved the quality of life or have they extended useful lifespan? How would you answer that question? Well, you would have to take people, pairs of people who have exactly the same condition, and you would have to treat one of them and leave the other one untreated, and they would also have to be matched for everything that could possibly be important, like age, sex, genetic predisposition, environment, diet, lifestyle. It is impossible to do that sort of a clinical trial. So what do? We use so-called biomarkers or surrogate markers. We measure blood pressure, we measure cholesterol level, we measure blood sugar, PSA, and so on the presumption that those things that we can measure are proper measures of the disease that we're trying, or the condition that we're attempting to follow. Well, are the surrogate markers valid? In order to find out whether any given surrogate marker is valid, you would have to do exactly the sort of impossible clinical trial as you would have needed to test a drug. So these biomarkers, blood pressure, cholesterol level, and so on, have been chosen because they have been found to be associated statistically, correlated statistically, with what we've called the disease. Now, a statistical correlation may not be valid in individual cases. The overall mortality increases as blood pressure increases, but given individuals may thrive on blood pressure levels that are 50% higher than the average. The statistical correlation does not transfer over to any individual case. But in any case, all of these surrogate markers are based just on correlations, and it's a fundamental fact of statistics and of common sense that correlation doesn't prove causation. My favorite example of that comes from a book 60 years ago by Darrell Huff, How to Lie with Statistics. And he mentions the correlation between the price of rum in Cuba and the salaries of Protestant ministers in Connecticut. The question is it the fact that those ministers' salaries were going up that allowed Cuba to ask more for rum? Well, obviously not. The fact is that prices and salaries both increased with inflation, and so there was a correlation between those two things. We tend to believe that correlations show causes when it seems plausible, but the evidence, just the correlation, doesn't prove the cause. As we get older, the incidence of cancer increases, statistically speaking. Incidence of organ failures increases. The incidence of heart attacks and strokes increases. Hearing deteriorates. Incidence of dementia increases. Blood pressure increases. Mortality increases. All those things correlate with one another. So does that mean that blood pressure causes cancer, hearing loss, dementia? They're just correlations. But not everybody seems to understand that. About 6 months ago, there were some news items of about a research study which had found a correlation between hearing loss and dementia. And there was even speculation about why that might be. As it gets harder and harder to hear, you stress your brain and you drive yourself nuts trying to understand what's being said. Shortly after that, my local newspaper carried this full-page ad saying hearing loss and dementia are linked. And of course, they suggested that everyone should get their hearing tested. And if there was any deficiency there, they should get a hearing aid in order to stave off Alzheimer's disease. That seems absurd, but you see, the evidence that high blood pressure causes cardiovascular disease is of exactly the same sort as the evidence that hearing loss causes dementia, or that dementia causes hearing loss. So these surrogate markers are simply not valid. And I'm not the person who suggests that. An Institute of Medicine report published in 2010 called Evaluation of Biomarkers and Surrogate Endpoints in Chronic Disease actually amounts to an attempt to advise how to minimize the damage from using surrogate markers. And they mention some surrogate markers that are not valid. For example, in the case of cancers, it turns out that the size of a tumor is not a valid measure that tells you about the prognosis of what is likely to happen. In cardiovascular disease, believe it or not, the Institute of Medicine says blood pressure is not a valid marker of the progression of cardiovascular disease. Neither is cholesterol, whether it's total or the so-called bad cholesterol or the ratio. Neither is the C-reactive protein, which has been in fashion, or another substance, troponin. Jarvinen et al. In the British Medical Journal last year talked about the true cost of using drugs to prevent disease, and they said flatly, there are no valid data on the effectiveness of statins, antihypertensives, and bisphosphonates. The antihypertensives lower blood pressure. Bisphosphonates are what we get in order to stave off supposedly osteoporosis. So I'm suggesting that the drug-based treatment of chronic ailments is a fundamentally misguided approach. It treats aging as though it were an illness. The illness is assessed by surrogate markers. Drugs are approved on the basis of how they affect the surrogate markers. And then we add to that the wrong presumption that drugs can be specific. There are many sins in the approval process of drugs. One of them is that in order to get a drug approved, all you have to do is to submit to the Federal Drug Administration the results of 2 clinical trials which have lasted at least 6 months. You don't have to tell them how many other trials you carried out. That accelerated approval was brought in as a result of the panic over the AIDS epidemic, when there was apparently no cure available, but it has become routine. One of the things that was supposed to be part of accelerated approval was that after a drug had been approved, there should be continual monitoring of what it actually did in practice. But there's been a thoroughgoing failure to do that. And it turns out that about 3/4 of all drugs approved in this way have no data from follow-up. And in fact, there is no system for reporting adverse events. doctors, individual physicians, of course, are asked to report when they see that a particular drug has had a bad effect. But individual doctors are given no guidelines for the various medications for what they should look for. So, you're a doctor, you're treating someone for a particular condition, you're using a drug that's been approved by the FDA, you presume that it's working, you notice that the patient is not getting better, maybe showing some other symptoms. The most natural thing for you to conclude is the drug isn't really helping, the illness is getting worse, but you don't immediately believe that maybe the drug is causing an additional problem. So even if there were some sort of a system of reporting adverse events, there is no guarantee that it could be efficient. And in fact, some observers have suggested that maybe 90% of the adverse effects of drugs are never reported to the authorities. Now, those were sins of omission. There are also sins of commission. Those two clinical trials on the basis of which the FDA may approve a drug are not, of course, the last data that we get about the effects of those drugs. And John Ioannidis, who has done a lot of statistical assessment of medical matters, looked at the 35 most cited biomarkers, and he found that in only 7 of those 35 cases did later data confirm what those two initial clinical trials had claimed. Even if the clinical trials were valid, there's always a problem because the clinical trials do not look at the people who will be treated with the drug after it has been approved. Now, part of that's inevitable and makes a lot of sense. If you want to consider whether something lowers blood pressure, you're going to do a clinical trial with people who have very high blood pressure. It gives you the best chance of seeing whether the drug works. So you try it out on people whose systolic is 180 or 200, something like that. You find it works, the drug is approved, and then doctors prescribe it to people whose blood pressure may be 140 and not 180 or 200. So there's no guarantee from the clinical trial that those results can be transferred to the population that will actually be treated. It's also the case that individual doctors can prescribe any approved drug for any condition, not necessarily those that it's been approved for. And a recent survey indicated that 3/4 of these off-label uses of drugs have no scientific evidence to back them up. 20% of all prescriptions are written for conditions for which the drug was not actually approved. In the case of the psychotropic drugs for mental illnesses, it's actually 30%. 1/3 of the drugs, antidepressants, antipsychotics, and so on, prescriptions are written by doctors, presumably usually psychiatrists, when that particular application of that drug was never approved. I've already mentioned that correlations are mistaken, should not be mistaken for causes, but the terminology risk factor is very sneaky. It makes you think that a risk factor actually is a risk, but it isn't. The risk factor is purely a statistical association. Another common sin of commission is that when the results of clinical trials are reported, and remember that the people who do the clinical trials are the drug companies or organizations, contract research organizations hired by the drug companies to do the trials. So they'll present the data in what looks like the most impressive way. So you found something that lowers the mortality from a particular condition from 4 per 100 to 2 per 100. And you report this as a 50% reduction in mortality. Well, I mean, who is not going to buy a drug that reduces your risk of dying by 50%? But it doesn't. It reduces it by 2% in this case. And in that case, the possible side effects may be worse than the potential reduction of risk. So we have sins of omission and commission in the approval of drugs, and there are wages of sin. In the 1950s to 1960s, 2 prescription drugs were withdrawn from use. In the 1970s, another 2. In the 1980s, 5. After accelerated approval was introduced, in the 1990s, 15 drugs were withdrawn, had to be withdrawn, and in the 2000s, 26 drugs had to be withdrawn. And what's more, the time between approval and withdrawal has been getting shorter and shorter. The anti-diabetic Resulin was on the market for only 3 years before it was withdrawn. The antibiotic Raxar for 2 years. Redux, to suppress your appetite, was available for only 21 months. A calcium channel blocker lasted a year, an analgesic 11 months, a gastrointestinal drug only 10 months. Now remember, there is no systematic way of gathering information about what a drug actually does after it's been approved. So for something to be withdrawn so soon after approval, there must have been truly horrendous incidents of side effects and fatalities in order to produce the evidence for the withdrawal. One of the other sins that's connected with drugs is the terminology of side effects. Side effect sounds as though it is something doesn't always occur, it's typically negligible and so on. But any given drug has many effects. And one of the indications of that is the penchant that drug companies have increasingly to reposition drugs. What does that mean? Once a drug has been approved, it's approved for a particular condition. Drug companies are keen to get it approved to treat other things also, because getting that approval is quicker and cheaper. Because after a drug has been once approved, it's regarded as safe. And so you don't have to prove that again if it's going to be repositioned for something else. You've probably all seen ads for Cymbalta on television. It was originally approved to treat anxiety and depression and peripheral neuropathy, loss of feeling in the extremities, and fibromyalgia. Peculiarly enough, all at the same dosage, even though those are very different conditions. Still, the company was looking for better sales, and so they successfully repositioned it under a different name to treat stress urinary incontinence. Now, it's not only that drugs have many different effects, they can have mutually contradictory effects. For instance, for this Cymbalta duloxetine, the company lists as possible side effects increased urination and also difficulty urinating. It may cause constipation, or it may cause diarrhea, and it may cause agitation, or it may cause drowsiness and unresponsiveness. So side effects is a thoroughly misleading term. Side implies that it's unintended, that it's atypical, that it's not important. But the drug doesn't know what it's intended to do. It just carries out its chemical action. A side effect sounds as though it showed up only infrequently, in only a few people. But that's in the typically short clinical trials. If something shows up as a side effect in 6 months, then you may be pretty sure that when people start taking this for years, that those side effects and others are likely to become much more prominent. What we're doing nowadays with chronic diseases is we're actually treating symptom-free illness. A very informative book by Jeremy Green, who is an MD and a medical historian. A book is called Prescribing by Numbers, relates how over the course of the last half century approximately, lab tests have come to supersede clinical examination. And I'm sure that you're all familiar with the mantra, know your numbers, know what your cholesterol level is, your blood sugar, your blood pressure, and so on. Now, it used to be that blood pressure that was too high, hypertension, would be diagnosed because people felt ill in some way. Severe headache, dizziness, blurred vision, chest pain. That's not the modern diagnosis of hypertension. You may have none of those symptoms. You can feel perfectly well. You can climb stairs without getting out of breath. But if your blood pressure is greater than 140/90, you're told you have hypertension, and you'll be prescribed drugs to lower that. Not long after measuring blood pressure became routine because the technique became easy, there was a rule of thumb in the medical profession that the normal blood pressure is your age plus 100. I looked at a bunch of data sets from different sources, and I think that those actually show it's more like 2/3 or 3/4 of your age plus 100 is normal with healthy individuals who don't feel any illness. But here's what the National Institutes of Health says. Normal blood pressure is lower than 120/80 most of the time. In other words, approximately what a 20 to 30-year-old person normally has in blood pressure. High blood pressure, hypertension, is 140/90 most or above most of the time. And if you're between those two, you have pre-hypertension. And very helpfully, the NIH tells you, if you have pre-hypertension, you are more likely to develop high blood pressure. Well, since blood pressure increases normally with age, that's absolutely true. If you have pre-hypertension, all you've got to do is live a bit longer, and you'll have full-blown hypertension. And the result of this definition is that about 1 in 3 adults in the United States is said to have hypertension. Here's a graph that shows that situation. Blood pressure increases normally with age. 120 or below is said to be normal, and that is the blood pressure that on average 20 to 30-year-olds have. By the time most people are around 60 years of age, they're at 140 and they're about to get hypertension. 75 to 80% of American seniors under this definition have hypertension. They're sick in the absence of any symptoms at all, and present practice is to prescribe drugs for them for lifelong use. Half a century ago, diuretics were first introduced to treat high blood pressure, which at that time was if people had severe headaches, dizziness, that sort of thing. At that time, cardiologists wondered whether that was a good idea, pointing out that the increase of blood pressure with age could be an attempt to compensate for other effects of aging. Arteries and veins become less flexible. Arteries tend to narrow a little bit. But we want the blood to get to the extremities, so it may take more pressure to send it there. And some of the cardiologists at that time suggested that the general administration of drugs to reduce blood pressure was a very dangerous experiment being carried out on the population. So I'm suggesting that the drug-centered treatment of chronic ailments treats normal aging as a disease, and it prescribes lifelong drug use irrespective of what the side effects are, and in absence of any valid evidence of benefit in terms of quality of life or extension of lifespan, which reminds you of the statement, the operation was successful, but the patients died. Now, about 100 years ago, more than 100 years ago, the Food and Drug Administration was founded because in the 19th century and by the end of the 19th century, there were quite a lot of people selling quack remedies. And at that time, people talked about snake oil salesmen peddling panaceas and elixirs of life. I'm suggesting that in terms of the treatment of chronic ailments, medicine has regressed a century or more, and we now again have snake oil salesmen peddling panaceas and elixirs of life. Except in those days it was individuals doing the peddling, and now it's corporations, pharmaceutical companies. But then again, that may not be so different, because nowadays we've learned also that corporations are people. Thank you for listening so politely.
We do have time for questions. Are there any questions for Henry? If there are a number of questions, could you please come up? If not, I'll do my best to kind of run around and give you the microphone that I'm holding in my hand. Whoops, thank you.
Good morning, Henry. Do you know anything about the difference between drugs that are what do they call them? You know, there's the regular drug, and then there's the
Prescription and generic.
The generic. Because some of them, I understand, I don't know if that's true, are made in China. And do we know what's even in them?
If it is only the active ingredient, then there's absolutely no difference. But the thing that people worry about is that with drugs manufactured overseas, there isn't the same sort of care taken about what goes in there and the same way of monitoring that.
So our pharmacists and doctors say, you know, no difference.
There shouldn't be any difference.
Yeah,
And in many cases now, generics are actually made by the same people who made the prescription drug.
Thank you for a very exciting talk. I want to know the issue of corporations peddling snake oil in the name of drugs. How do we say political issue and a social issue? Because people are suffering. What can an organization like SSC do in terms of public education to deal with this kind of a problem? It's a worldwide problem, not just in the US. Your thoughts will be appreciated.
Thank you very much. I mean, this is a problem that is general for people in academia as well as in this society. How do you get people to notice what the evidence is? And, you know, these things have developed very slowly. One of the things that I found very interesting was that some decades ago, the CEOs of pharmaceutical companies were people who had come up through the technical side. When it was first suggested that drug companies should be allowed to advertise direct to consumers, as we see nowadays, the CEOs of the drug companies said that was a bad idea. Nowadays, the CEOs of drug companies are typically people who have come up through the marketing and sales side. So the whole culture of drug companies has changed. And again, this is something that has been documented but ignored. Marcia Angel, who was an editor of the New England Journal of Medicine, about 8 or 10 years ago, published a book called How the Drug Companies Deceive Us and What to Do About It. Now, there was a knowledgeable, prominent voice that has had no effect. And part of the reason, of course, is that the drug companies make such big profits that they can support many congressional campaigns. I wish I knew what to do about it.
Oh, thank you very much for a very interesting talk. You carefully steered clear of the whole system-wide healthcare debate, which is going on right now, costing us a bloody fortune. But lifestyle issues seem to be something that doctors are either ignorant of or they don't get any kickbacks from that, so they simply don't often suggest them, and they seem to be probably the most beneficial when it comes, diet, right, exercise, fresh air, and so on. But there also are some legitimate basic research being done, like genetic engineering. Cindy Kenyon at University of California, Aubrey Gray, speaking of immortality, that type of thing. Any comments about those? Well,
It's true that research money is not available for those things because other things are more flashy and attracted. Colin Campbell wrote a book, The China Study, in which he talked about the relationship of diet to cancer on the basis of work that he himself had done. And he mentions that the only way he was able to get this work funded was by calling it Studies of Cancer and not studies of nutrition or diet. So it's also the case, I think, that it's very difficult to get good data about lifestyle issues because you have to depend very much on self-reporting by people of how they feel. And even if you're honest about it, you're not always right about what's going on.
Well, as a physician who worked at a heart hospital with nutrition, exercise, and stress reduction, and do not believe that adult onset diabetes is a disease, but rather is a symptom of our society, I found that my medical peers did not believe what was happening, that non-drug treatment would be so effective. And it actually is a solution to the multi-billion-dollar health care crisis we're in. In the mid-90s, the only education I could receive was through pharmaceutical companies, so I dropped out of CME, or continuing medical education. The pharmaceutical companies brainwash physicians, and most of them really just don't believe it or don't know what's going on. So it is a grassroots issue.
Yeah. And, you know, we hear the statistics that so much of healthcare costs are spent in the last year or two of life, and that older people are being given so many medications. We could cut the overall cost of healthcare dramatically by stopping doing things that don't do us any good.
Henry, that was a splendid talk. Thank you very much.
Thank you.
I just want to say that we are not helpless in the face of the corporations, the pharmaceutical companies. A couple of years ago, there were 2 international studies which really flew under the radar screen pretty much of the profession, showing that with attention to diet, exercise, and stress management and stopping smoking, 3/4 of all heart disease could be eliminated from this culture, and also 2/3 of all cancers eliminated, prevented. This is astonishing stuff. And when we grope for what we can do, it's already clear that we have potent options. And they're so potent, as a matter of fact, that they simply aren't noticed. But my point is that, you know, we are not helpless. I mean, we really do have some big guns to play in all of this.
The problem is to spread that message to everyone who can benefit from it. And there are powerful forces that oppose it. A known side effect of statins is muscle weakness. And it's known also that statins not only affect the making of cholesterol, but they also affect the generation of ubiquinone, known also as coenzyme Q10. And coenzyme Q10 is an essential ingredient in every energy-producing reaction, in every cell in our bodies. A friend of mine, who is a biochemist, approached one of the large pharmaceutical companies and said, look, you should market something you can call a superstatin. You add coenzyme Q10 to it and you reduce the side effects. And the technical people in the company were very enthusiastic, but it was vetoed by the legal department, who said that if we start doing this, we will be admitting that we knew that it has that side effect, and we'd get sued.
Hi, Henry. My name is Eric Schultz, and I'm from Leiden University Medical Center. There's something going on in the pharmaceutical industry now. There's kind of a crisis that a lot of the blockbuster patents are coming to an end. And in the last 20 or 30 years, it's been impossible for the pharmaceutical industry to replicate the kind of research that translates into IP. And so I think even within 5 or 10 years, the pharmaceutical industry is looking at a major downsizing, and it's already beginning to happen, I know, with the people that I work with. So I'm just wondering if you could comment maybe on what's going on in the last 20 years.
Well, I think that the drive to reposition drugs is one indication that the companies are looking for ways to keep their business going. I was interested quite recently to see that Cialis has been repositioned to treat enlarged prostate, for example. I think one of the growth areas that they're going into is vaccines. And one of the disasters of that already is Gardasil. Gardasil is a vaccine against a few strains of human papillomavirus, which were found to be correlated with cervical cancer. And the FDA approved this vaccine, which is very expensive, and there have already been something like 30,000 negative effects of Gardasil. And you may recall that people have been enthusiastically suggesting that every girl be vaccinated by that. Governor Perry did that in Texas for a while. So I'm afraid that one of the things that's happening is that the drug companies are looking to more and more unwarranted ways of selling things. And they do it because they're able to advertise to the general public. And what parent, of course, wouldn't want to guard their daughter against cervical cancer? This happened, by the way, at the same time as for about 20 years the incidence of cervical cancer had been going down anyway.
All right, thank you very much. Please join me in welcoming.